Yes, so I was asked to give a little summary of the trial and then showcase this. This lecture theatre is giving me PTSD from my university days, actually, with all these ranks of people staring at me. Okay, so I was asked to show a case that could easily have been in the trial, and also to give a couple of comments about the trial itself. So the first thing that amused me was the flexible non-inferiority margin. That's a new one for me. I did like the way that potentially we could just move it along if it wasn't quite where we wanted it to be. But the key thing out of this study is that this number, 4.4, and the number next to it, 5.3, are very similar. And what that means is that there isn't much difference between these two treatments, whatever the statistical jiggery-pokery is next to it. And what also is true is that this line and the other line are very close together. Okay, and that also means there's hardly any difference between these two treatments, and we don't need a statistics PhD to understand that. We also saw some little differences between the groups, all hypothesis generating, but I think most of them actually were in the direction that you would expect, and I won't labour the point there. But I do want to say a couple of things. I've been slightly underwhelmed by the euphoria in the room today, because this trial, boy, was this a brave trial to do. And despite incorporating operators' experience, most people in this trial were relatively new to this technology. And we can see that because there was a 20% stent implantation rate. That's high. So despite incorporating that, and despite reporting at 1 year, when the stent failure rate hasn't yet happened, it's low at 1 year. Despite that, it met the non-inferiority margin. And that was impressive, and I wasn't absolutely sure it was going to do that. But what it does mean, and hands up who agrees with this, superiority will follow in 5 years. Now, come on, you're at the DCB meeting. Okay, fewer of you than I thought. Anyway, I have no doubt superiority will follow. And so I'd like to say that for me, this trial absolutely represents a quantum shift in interventional cardiology. You know, stents were not intended when they were first used to be the be-all and end-all, implant a stent in every single anatomy. Even Ulrich Sigvart said, no, 80% of lesions shouldn't need a stent. But we got to use them everywhere because they gave us beautiful results now, maybe ugly results later, whereas what we've got to get used to is having ugly results now and beautiful results later. This is a massive shift, and for me, this is the single most important clinical trial in coronary artery disease since the advent of the coronary stent. Having said all that, back to something a little bit more mundane that everyone's used to, and we've seen quite a few cases like this actually, so it's not particularly unusual. But so a 55-year-old man, history of smoking and hypercholesterolemia, presented with a troponin-positive ACS with biphasic T waves in the anterior leads, and I was asked to choose a case that would get people to think, oh, I might put stents in this. So I'll let you have a look at all that. The right coronary dominant, a bit messy, maybe something physiologically significant in the mid-vessel, maybe not, but remember he had anterior ECG changes, and then you can see really the main problem is in the LAD. Does anybody want to say that they'd put stents in it? No, of course not. You're at the wrong meeting if you're going to say that. So I think I'll probably just show the case rather than have lots of discussion about it, because it's similar to many of the other cases. So the vessel was wired, and you can see there's quite a lot of disease along a diffuse calcified vessel. So it was initially treated with a 2mm Trek balloon, then a 2.25 non-compliant balloon, bit by bit by bit. It's quite slow doing this, it's methodical. Okay, so it starts to look a little bit better. Then we use a 2.5mm non-compliant balloon, high pressures. You can see we're getting some nice linear dissection visible in the mid-vessel now, so we know we're actually opening things up a bit. And then as is usually the case, certainly in our department, we're very keen on the cutting balloon, one-to-one size, but lowish pressure. And often we do the thing where you try to rotate the cutting balloon a little bit by pushing it down the vessel, twisting a tiny bit on the hub. I don't know if it really works, but it makes me feel like it works, and pull it back, go again and again, 3 or 4 times, low pressures along the length of the vessel. Okay, it's coming, it's getting better, it's getting better. And then try to get rid of our entire budget. In one case, we're going to do 3 solution balloons along the length of the LAD. So that's the final result. Of course, it's not perfect. It's not going to look perfect. If it looked perfect, you know you hadn't done a good job, because you haven't actually dilated the lesions and caused dissection. And then he came back a few months later in the UK. Whether he really needed to come back and have the right looked at, I wouldn't like to say, because he didn't actually have any symptoms anymore, but he did come back, and so we've got some pictures. And you can see that the LAD, okay, it's not pristine, it's a little bit fluffy in the middle, but it's TIMI3 flow, and he has no symptoms of angina. And that's the worst it's going to look. As the last speaker suggested, you know, any kind of remodeling has already happened. Now he's free of angina. That's the purpose of our angioplasty procedure. So, and that's the end of the angiogram. Thank you very much.